Okay, so this is the therapy unit at Mile End. This is, we sometimes call this the Mile End Mothership. It's the sort of heart of the physiotherapy department across the trust. And sports gym is a rehabilitation area, not just for people with sports injuries, but any musculoskeletal and patient condition. And across the trust, we have between 2,000 and 2,500 referrals per month for outpatient physiotherapy. And those are referrals from GPs, from orthopaedic surgeons, from rheumatologists, from across all the specialties that deal with musculoskeletal problems within the trust. And really, I guess that's one of the real strengths of therapies and of CSS and of Bart's Health, is that we've got this incredible referral base, an incredibly diverse population, right from elite athletes through to elderly people, all sort of ranges of ethnicities and socioeconomic backgrounds, of course. So we have a range of trials going on at the moment in the musculoskeletal field. For example, the TEAM trial, which is a trial of 3 novel approaches to tendinopathy, Achilles tendinopathy in this case. We've got trials happening in relation to patellofemoral pain, the most common knee problem that people get, and so on. And there's a range of trials in orthopaedics. There's an excellent infrastructure there, and also in rheumatology. And we're very lucky because Bart's Health sits alongside Queen Mary. We've got incredible collaborators, 2 clinical trials units within QM and the Trust, so we can really deliver the support that external research needs, as well as generating our own account and our funded research activity. And this space that you're in, sort of, I think, typifies a lot of what we do. We're delivering excellent clinical services. We're delivering excellent education, so this is very much linked to the Sports and Exercise Medicine MSc and Intercalated BSc, which is hosted through QM, but very much links to the clinical services here. We have a superb in-service training package for physiotherapists, and the reason that's important is that often clinical research is effectively delivering innovative clinical services in a slightly different way, so that we collect the data with the rigour and with the controls that we require to minimise bias and to maximise our learning from that innovation. And in order to do that, I've learned through my NIHR fellowship, but equally through my participation in other trials. In order to do that, you've got to have a robust clinical governance and in-service structure. You've got to have really well-managed clinical teams who can take forward innovation, incorporate it, and do it with the kind of rigour that is required in order to answer the question. So this is a good place to do research. We've got the infrastructure, we've got the patient numbers, we've got the expertise, and there's all sorts of aspects of what we do that can be tapped into. We sat here in this very space just a week and a half ago having a PPI group, a patient and public involvement group, which was really heartening and taught us lots of lessons about the kind of research that we're planning going forward. And one of the key messages from that was around research informing clinical care for individual patients as we go along. And there's some challenges there about not compromising research, but equally allowing patients to have access to their records, and clinicians to have access to any tests and investigations that might happen, or any treatments that might come out of their participation in a trial, for example. The other bit that we do, as well as looking at effects, because effectiveness trials and efficacy trials are really the key thing that the NHS needs to be looking at. But in order to get there, we've got to look at mechanisms. And a lot of physiotherapy research, which has blossomed in the last 20 years. When I was an undergraduate student, there was very little research to to guide our clinical practice. Now we've almost got the opposite problem. We've got too much and we're trying to pick that apart, and that's a great problem to have. So we need to know about efficacy and effectiveness, but we need to know about mechanisms. And we do a little bit of that work within the Trust, but we're also very lucky to have the input of lots of QMUL facilities and academics in order to explore the mechanisms underpinning the effects that we see in treatment environments like this. So you're in the Human Performance Lab, which is funded or is run through Queen Mary, and it's a joint venture between engineering and sports and exercise medicine, but has also been part funded by the Trust. And what we've got is a 4-camera motion capture system set up. Just now we have 5. We've got ground and bed force plates on an instrumented treadmill here, and what you can see is we're just getting used to some initial walking and treadmill position, and we're measuring muscle activity through these devices and position of the limb through the different markers. So these are very accurate motion capture markers, and this is feeding into a project actually where we're trying to explore the analysis of gait from a statistical perspective. And we're doing a lot of statistical analysis of existing data sets and new data sets such as this in order to better understand how we can learn the sort of intricacies of how an individual moves and describe the pathology better. It's linked to some work we've done for a few years with children with cerebral palsy who come in and have their gait measured in order to inform surgical and injection and orthotic interventions in orthopedics particularly. We also have respiratory analysis, so fitness type testing, EMG analysis, we have some imaging down here, and a range of other tools to look at aspects of human performance, whether that's in young obese children through to elderly exercisers, through to elite sports people. We pick up them all in the lab at different times.